We are live now. Three, two, one. Yes, ma'am.
Thank you. Thank you, Chitra. Thank you so much. Welcome to the academic wing of assisted reproduction's webinar for the month of November. We're extremely pleased to have a great speaker, Dr. Tuwej Dalal. And this topic is extremely important for every gynecologist because when we see male infertility, we just shut down and then we just, the patient shunted from one gynecologist to the other. Nobody knows what needs to be done and the patient is left like that, and at the older age they come for different types of treatment. So we need to know how to evaluate such a patient and manage him appropriately so that the infertility part is taken care of. So for that we have got a great speaker, and I'm extremely honored to introduce Dr. Shanti Priya, our EC member, who will be introducing the speaker to the forum. Welcome, Shanti. Please introduce a speaker.
Good evening. I'm Dr. Shanti Priya. On behalf of Academic Wing of Assisted Reproduction, Trichy, Tanjore and Tiruvarur Wing, it is my great pleasure to introduce Dr. Rutvij Dalal. Sir is Director of Janini IVF Delhi, and Sir is DGO DNB FNB in Reproductive Medicine at Leelavati Hospital, Mumbai. Sir has presented many international and national publications in many forums. To his credit, he was awarded ISAR Manish Banker Young Achiever Award, CS Don Best Paper Foxy Prize in AICOG 2011, 2012 and 2013. And Milan Brightest Young ART Talent of India Award in the year 2013, and recipient of Foxy Best Young Scientist Award in 2014. And Sarah has contributed in various textbooks and co-author of Reproductive Endocrinology and Infertility by BI, and publications of many publications and author of many other books. And he has reviewed more than 100 original manuscripts, and Sarah has invited as a speaker in several meetings. Dr. Rudvij is going to talk on the topic, what should a gynecologist should know about the workup of azoospermia. Over to you, sir.
Thank you, ma'am. Thank you for the very kind introduction. At the outset, I would like to thank the dignitaries and especially the organizing dignitaries of this forum to give me the opportunity to speak today. So I'll be sharing my screen and giving the presentation. The topic of today's presentation is how what should every gynecologist know about evaluating a patient of azoospermia. I hope my slides are visible.
Yeah, they are visible. They are visible.
Okay. So I am starting my presentation. It is evaluation of azoospermia. And as we all know, the definition of azoospermia is complete absence of sperm in the ejaculate. It is prevalent about in 1% of all the men, and it is about present in 10 to 15% of all infertile men. Here, the term azoospermia is very important because it has to be discriminated with aspermia, which is complete absence of ejaculate. It is distinct from azoospermia, and it is complete absence of seminal fluid emission at the time of ejaculation. Whereas azoospermia, there is ejaculated fluid, but only thing is the sperms are not there. So it is very important to discriminate between aspermia and azoospermia. So azoospermia can be classified into three primary categories. As we all know, it could be pre-testicular in cause, it could be testicular, it could be post-testicular. Usually we see that testicular causes and post-testicular causes are irreversible or they require some surgical intervention, whereas pre-testicular causes are usually correctable, but there are exceptions to this rule. So pre-testicular could be a secondary testicular failure, and they are often correctable. Testicular causes are usually primary testicular failures, and they have intrinsic pathology, and they're usually they are called as non-obstructive azoospermia, and they are usually not correctable, or they are correctable only after with surgical retrieval of the sperms. And post-testicular usually of obstructive pathology, and they are correctable in 40% of cases. So looking at primary testicular failures, I already said that they are usually non-correctable. And one exception to this is varicoceles. Varicoceles are testicular failures with presenting with azoospermia, but they are easily correctable after doing a good surgery like micro varicocelectomy, etc. Pretesticular is also called, could be mainly due to hypogonadotropic hypogonadism, and it could be congenital as seen in Kalman syndrome. It could be acquired in cases of brain trauma, tumors, infections to the meninges, radiotherapy or drug induced, or it could be idiopathic also, in which case we can diagnose it easily by doing a panel of hormonal investigations like FSH, LH, and total testosterone. Testicular could be primary failure of the testes, and it could be congenital as seen in Klinefelter syndrome, which is XXY, and it could be due to genetic causes, chromosomal microdeletions. It could be acquired as seen in radiotherapy, chemotherapy, torsion, orchitis, etc., or developmental as in testicular maldescent. And idiopathic is the most common. Even today, idiopathic testicular failure is the most common reason of testicular failure. Here, I'd like to ask the panel if I'm being audible and if the slides are visible, everything is in order.
Yes,
Okay.
it's visible.
Thank you, madam. Thank you. Post-testicular causes are mainly obstructive in origin, and the obstruction could be at any level, right from the intratesticular ducts to the reed testis to epididymis to vas deferens, all the way to even ejaculatory duct obstruction. And there could be various reasons of these obstructions. These obstructive pathologies are usually due to infections or trauma or surgical damage, which could be iatrogenic, or in some cases like epididymal obstruction, it could be Young syndrome. In cases of ejaculatory duct infection, it could be urethral surgery, etc. But usually these are infective in origin, and the obstruction could be anywhere, just about anywhere. And it takes a very good urological investigation or even vasography in some cases to find out where the obstruction lies. But first thing is we have to discriminate between obstructive azoospermia with non-obstructive azoospermia, and the following slides will help us in determining which is the cause. One more reason of azoospermia we have to often remember and not completely miss out on is ejaculatory dysfunction, in which case the ejaculation is completely at a problem, and otherwise the sperm production and there is no obstruction as such, but there is ejaculatory dysfunction, and it could be due to various reasons like spinal cord injuries, multiple sclerosis. Diabetes is a very important cause, very common cause, and we have to keep ejaculatory dysfunction in all diabetic patients in mind. Bladder neck surgeries, prostatectomy, etc., are other reasons of ejaculatory dysfunction, and we have to often think about it, remember it, and we can find out if the patient has ejaculatory dysfunction by doing a urine analysis of such patients, and seeing the presence of sperm in the bladder. After doing a catheterization of bladder is diagnostic of retrograde ejaculation or ejaculatory dysfunction. So again, how to diagnose and what to do in further diagnosing these patients. If no spermatozoa can be detected on high-powered microscopic examination of a pellet after centrifugation, this is very important. We have to centrifuge the sample on at least 2 separate occasions, 4 weeks apart. That's what the World Health Organization recommends. That seminal fluid should be centrifuged for 15 minutes at 3000 G or greater. And those 2 examinations should be at least 4 to 6 weeks apart. Why? Because 15 to 20% of all azoospermia diagnoses may be wrongly diagnosed. They could be cryptozoospermic, which means they have some very few sperms. After their centrifugation is done, these sperms are found, and these patients are then called cryptozoospermic and not azoospermic. So it is very important to centrifuge the seminal fluid on at least 2 ejaculations. Now I'll be starting to talk about the initial evaluation of every azoospermic patient. So initially, we have to take a complete medical history. We have to do a thorough physical examination, semen analysis, of course, measurement of selected hormones in some cases, imaging studies, and genetic analysis. And I'll be going through each and every aspect of these examinations in detail. So to start off with, we have to take history of presenting complaints, and we have to diagnose whether the infertility that the couple is having is primary or secondary, and the duration of infertility is important. In order to discriminate testicular failure with other pathologies, testosterone could be a very valuable marker. And instead of doing a blood testosterone, which we can do anytime, Even asking basic questions like about libido or importance or frequency of intercourse, we can find out whether the patient has been suffering from a low testosterone level. In medical history, we have to rule out recent febrile illnesses. We have to ask about mumps or TB orchitis in the past, any venereal diseases, if there is any history of liver or kidney issues, if the patient has received a radio or chemotherapy in the past. History of multiple sclerosis would be obvious. History of diabetes and spinal cord injury has to be taken into consideration for various causes like testicular damages to ejaculatory dysfunction. We have to take a thorough surgical history, any history pertaining to the reproductive system, particularly near the inguinal area like orchidopexy, vasectomy, inguinal hernia repair, prostatectomy, sympathectomy, and even pelvic, scrotal, or urethral surgeries can be responsible for the azoospermia, as they can cause iatrogenic obstruction or sometimes even ejaculatory dysfunction. We have to take testicular history. We have to ask if the patient had any mild descent during his childhood, if he recently suffered from any trauma or torsion of the testicular area, because it could lead to testicular damage and testicular failure. In drug history, we have to ask for certain specific drugs which are anti-androgen, androgenic in origin. Some of them include cimetidine, spironolactone, which is a diuretic, anabolic steroids, GnRH agonist, depot or long or analogs, and even chemotherapy for cancer. These all are usually anti-androgenic or anti-testicular, and they can cause permanent or temporary testicular damage. And we have to rule out all these drug histories. In occupational exposure, we have to rule out excess heat, radiation, exposure to drugs or alcohols, and environmental pollutions. In systematic review, we have to ask for headache or visual disturbances, because these can be due to pituitary defects, which can then lead to pre-testicular failures because of hypogonadotropic hypogonadism. We have to ask for anosmia, which can be seen in Kalman syndrome, presence of galacturia, which could be because of hyperprolactinemia, recurrent respiratory tract infections. This is very interesting because patients with Young syndrome often present with recurrent respiratory tract infections because it is an immotile cilia syndrome. The cilia does not function, leading to recurrent respiratory tract infections. Again, gynecomastia has to be seen or checked for or even asked for, because it can show it can be due to hormonal imbalance, higher E2P or testosterone ratio. In previous management, we have to ask for previous investigations and treatment, and the rationale is to avoid unnecessary delay or repetition in both instances, in investigations as well as treatment. Here again, I would like to confirm if everybody's with me.
Yes, we can hear. Yeah.
Okay, thank you. In general examinations, we have to look for body proportions, and the body proportions would include the arm span and the leg span, the height of the person. We have to look for beard growth, presence of anosmia and gynecomastia. In specific reproductive tract examinations, the penile examination would include examinations of parts like urethral meatus. We have to look for any ulcers or discharge, scars, and abdominal curvature and angulation of the penile shaft. In scrotal, we have to look for any scars. The testicular position, this is very important. The testicular volume and consistency is also very important, because it can prognosticate the presence of sperm in a successful surgical retrieval of sperms, especially the consistency. And we have to check for lumps or any masses, which can often indicate testicular tumors. In vessel examination, which could be done very easily clinically, we have to check for presence or absence of vas, because one of the reasons of azoospermia could be a congenital bilateral absence of vas deferens, as seen in cystic fibrosis gene mutations. We have to look for nodules, irregularities, and tenderness of both the bilateral vas deferences. In epididymis examinations, we have to check for nodules, irregularity, tenderness, and cystic distension. Here, I would like to emphasize on the fact that epididymis, if they are normal, they are usually not palpable or tender. But however, if they are suffering from pathologies or infections or tumors, then there would be nodularities or tenderness, or even nodules and cystic distension found, which is abnormal. Varicocele is significant only if it is either grade 2 or grade 3. Grade 1 is palpable during Valsalva's Benomere. Grade 2 is palpable without Valsalva's Benomere, and grade 3 is visible distension. So only grade 2 and grade 3 are of any clinical significance, and we have to look for them. Of course, any varicocele diagnosed only with ultrasound examination and not through clinical examination are not significant as far as fertility treatment is concerned. Rectal examination then can be done particularly if we suspected ejaculatory duct obstruction, and we have to look for tender swollen prostate, consistency of the prostatic gland, and we have to even check for distended seminal vesicles. Inguinal region examination has to be done thoroughly. We have to look out for hernia, lymph nodes, any surgical scars, or even inflammatory scars that could be present in tuberculosis and lymphogranuloma venereum infection. Semen analysis is important, and usually the box as the chart is mentioning, the rules apply here. If the patient is suffering from obstructive azoospermia, especially ejaculatory duct obstruction, then these kind of patients usually will have a low volume semen and have a acidic pH. The pH will be less than 7. And non-obstructive patients usually have normal seminal volume, that is more than 1 ml, and normal pH as well, more than 7. However, there are exceptions to this rule. This is only correct in about 70 to 80% of instances. There are exceptions to this rule, and one has to keep these exceptions in mind. And why is so? Why are non-obstructive azoospermia patients having normal seminal fluid? Because the testis itself contributes to only about 8 to 10% of the seminal ejaculate. If you look at the ejaculatory fluid, 70% of the fluid comes from seminal vesicles, 20% comes from the prostate, only about 8 to 10% comes from the testes, and there are corpus gland secretion which contributes about 0 to 2%. So majority of the secretion is coming from the seminal vesicles, and therefore the patients with non-obstructive azoospermia will have a normal ejaculatory fluid. They will not have less than 1 ml ejaculatory fluid. Fructose can be seen, and this can be discriminatory between obstructive versus non-obstructive azoospermia. They can help us in diagnosing obstructive azoospermia more clearly. They are produced from seminal vesicles, but no need for fructose as a routinely. We can do it if there is a mismatch between a pH and volume. So if this is the box I said is correct in 70 to 80% of the times. If this box is not correct, if this box is not being followed in a particular patient, then we can look for seminal fructose and see whether the fructose is positive or not. What about endocrine evaluation? So the initial endocrine evaluation should include measurements of serum total testosterone and follicular stimulating hormone. Always remember that in men, when we look out for testosterone, it is always total testosterone. And when we look for testosterone in females, which is often done in cases of PCOS or hyperandrogenism, we look out for free testosterone. So in females, it is free testosterone, and males, it is always total testosterone. This is a rule. Again, normal FSH is not a prognosis, excludes testicular cause, but anything more than or double the normal levels, anything more than 20 usually indicates a testicular pathology. So this is the interpretation of FSH, LH, and testosterone levels. In spermatogenic failures, usually FSH is high and testosterone is low normal or normal. In cases of testicular failures due to Klinefelter syndrome, again FSH is high and testosterone is low. If there is a hypogonadotropic hypogonadism, obviously everything is low, FSH is low, LH is low, and testosterone is low. And in cases of exogenous testosterone exposure, as often seen in bodybuilders, testosterone is high. And because of negative pituitary feedback inhibition, FSH and LH is low. So we have to even ask for exogenous testosterone exposure, which is often seen in bodybuilders and athletics. Additional hormone can be done. One is serum prolactin, and it can be done in cases of clinical hypogonadism, sexual dysfunction, galactoria, or if there is any suspicion of pituitary adenoma and gynecomastia. And we can also do serum HCG and estrogen, particularly in cases of gynecomastia, because it can indicate certain tumors or testicular tumors, and or even hormonal imbalances. Transscrotal scan is actually, ironically, the most commonly done investigation, but practically it has no role in male infertility. Almost all findings that can be elicited clinically, like varicoceles, spermatoceles, absence of vas, epididymal induration and testicular masses are clinically relevant and significant, they don't need a transscrotal scan. We can easily do a good clinical examination and rule them out. Doppler may diagnose minimal varicosis, but they are not clinically significant. So why are we doing it in the first place? Scrotal ultrasound may be useful to clarify ambiguous findings on examination or in cases with difficult palpation, like excessive scanning, etc. And that's where transscrotal scans probably are helpful. Otherwise, transscrotal scans do not deserve the frequency with which they are done, as we see in our clinical practice. On the other hand, transrectal scans are very important because they, particularly when we suspect a ejaculatory duct obstruction or obstructive azoospermia, like in low volume ejaculate and acidic ejaculate, they can easily diagnose pathologies like ejaculatory duct obstruction, seminal vesicle agenesis, midline prostatic cysts, etc. So transrectal scans are in fact more important than transscrotal scans. And normal seminal vesicles are less than 5 centimeter anterior-posterior diameter. If they are more than that, it usually indicates ejaculatory duct obstruction. So transrectal scans are usually very helpful, very useful, particularly when we suspect a ejaculatory duct obstruction. Genetic screening can be done, and there are 3 common genetic factors that we should be aware of in every cases of azoospermia. One is cystic fibrosis gene mutation. I already said that, and it is usually associated with congenital absence of the vas deferens. Second is chromosomal abnormality, testicular function. This could be Klinefelters as seen in XXY, or even autologous chromosomes, inversions, deletions, or translocation of chromosomes can be responsible for abnormal semen testing. And third thing we have to take care of is Y chromosomal microdeletions, and we have to look for a particular segment of the Y chromosome, and they are often associated with isolated spermatogenic impairment. Usually, clinically, the patients are fine, but only the sperm production is impaired. So cystic fibrosis gene mutations, there is a strong association between the congenital bilateral absence of vas deferens and mutation of the CFTR gene. This gene is located in chromosome number 7. Almost all male patients with clinical cystic fibrosis exhibit congenital bilateral absence of vas deferens. Conversely, approximately 2/3 of men with congenital bilateral absence of vas have documented mutations of the CFTR gene. One reason why only 2/3 of men have CFTR gene mutation is because CFTR is a complex gene, and there could be still certain mutations of this gene which have not been discovered yet. So maybe this gene is still responsible in those 1/3 as well, but we are just not aware of those mutations. And again, failure to detect a CFTR abnormality in men with congenital bilateral absence does not rule out the presence of a mutation, as I already said. What about karyotyping chromosomal abnormalities? Should we do a karyotype? Absolutely, yes. It could be present in 7% of infertile men, and the prevalence is 10 to 15% in azoospermic men. Klinefelter syndrome is also very important. It accounts for about 2/3 of chromosomal abnormalities, and other problems could involve autologous chromosomes, in which there could be ring chromosomes, translocations, both reciprocal as well as Robertsonian. There could be inversions, there could be deletions, etc. Y chromosomal microdeletions are found in about 10 to 15% of men with azoospermia, so it is very important to do them as well. They could be found using the polymerase chain reaction test. They usually occur in non-overlapping regions of long arm of the Y chromosome, that is YQ11 segment. And there could be three segments that are most commonly found. They are designated as azoospermia factor A, which is more proximal, azoospermia factor B, central, and azoospermia factor C, which is distal. Azoospermia factor C deletion usually has a good prognosis, and it can help us in prognosticate successful sperm harvest during the surgical retrieval, and we can advise the couple to go for a TISA or a TC or a micro TC if particularly azoospermia factor C is found, and they can be positively encouraged to go for a micro TC ideally, so that they can have the offspring with their own sperms. Whereas the people with a diagnosis of azoospermia factor A and B deletions usually have a poor prognosis of finding sperms during a surgical sperm harvest. So with that, that was the last slide. I thank you all for giving me this opportunity, and I welcome any questions that any of you might have. And thank you so much for being with me.
Thank you. Thank you so much, Dr. Utvaj. That was excellent, actually. Very, very, very precise. So let me just summarize. So it will be like when you have a patient with azoospermia, the way you should manage is always the semen analysis has to be done twice, and preferably it should be done in a centrifuge sample.
Absolutely,
right?
Absolutely, madam. Centrifugation is mandatory, and it should be done at least
And
twice before turning
centrifugation is mandatory. Azoospermia, and then you should elicit a history where it includes drug history and any past surgical history and any medical history, because all that can affect the semen sample, right?
Absolutely, and
And
also thorough
after the
medical
history
and genetic history.
Genetic history is also mandatory, and but a physical examination should be on par. That no gynecologist does, according to me. So
yeah, I think that's the crux of the problems, because usually the gynecologists are female, and particularly in your part of the country, they are
yes.
all female. They are reluctant. They are sometimes embarrassed or psychologically reluctant to pursue a thorough physical examination. And that's where we at least should be looking out for basic physical aspects of the reproductive system. If not, as detail as a urologist would do, that is not expected out of us. But at least as far as basics, basic scrotal examination, testicular consistency, penile examination, etc. is concerned, we should be looking out for those things to at least have a clinical understanding of the pathology, and we can prognosticate the patient about the chances of finding sperms if we are going for a surgical sperm retrieval.
And testicular volume should we do in a physical examination? All those
orchidometers.
Orchidometers.
No. Once we have a clinical assessment of the volume, I think that should be enough. There could be orchidometers that could be used. Otherwise, one can go for a transscrotal scan also, but it is not mandatory. Any decently sized testes vis-a-vis an abnormally sized testes would be very apparent clinically, and we don't have to be precise in the measurement.
Oh. And then the next part is the semen analysis, where the volume is extremely important to differentiate between obstructive and non-obstructive azoospermia.
Yes, ma'am.
Yes, because many of us do not even see how much volume the patient has produced. So we just go ahead and then do the blood investigations without even checking whether the volume is normal or not, because we think that that is beyond this thing. But it's a very, very simple thing which you emphasized on, and that's a very great take-home point. Always check for the volume to see whether it can be non-obstructive or obstructive azoospermia. Then go for the blood investigation. So it will be total testosterone and FSH-LH. Is that right? Yeah.
Correct.
And FSH-LH, is there a particular time you'll do testosterone, FSH-LH?
No, anytime.
Any time of the day you can. When the patient walks in, he can do total testosterone, FSH-LH. And prolactin, is there a particular time? Prolactin
can be done in specific cases, like if the patient has a history of gynecomastia, or if there has been a breast discharge, or if he has a sexual dysfunction, or if there are any clinical signs like low testosterone levels, then we can do a serum prolactin. And if we are doing prolactin, then it is important to do it early morning, fasting sample.
Yes. Okay. And then you said scrotal scan doesn't help much when you go do a good physical examination, and rather a transrectal scan will be much better.
Yes, absolutely, madam. Absolutely. And this is against what we find clinically. Clinically, we always see patients in the OPD who have hundreds of transscrotal scans done. But transscrotal scans usually look out for abnormalities which are usually apparent clinically, and only then they are significant. So as I already said, varicocele can be diagnosed by transscrotal scans, but any varicocele of grade 1 are not clinically significant. So there is no point in doing transscrotal scans, actually.
Because it doesn't add to the treatment modality.
Exactly.
And then we'll go for a karyotyping when you suspect that there's a genetic cause, or you'll do for every patient with azoospermia a karyotyping.
Every patient with azoospermia and severe oligospermia, any count less than 5 million, should go for Y chromosomal microdeletion and karyotyping ideally. Both.
So you have to mention that you need a Y chromosome microdeletion. Just asking for a karyotype may not be helpful at all. Is that right?
That is correct, ma'am, because we could be missing out on Y-chromosome microdeletion,
Microdeletion.
especially azoospermia factor C in cases of severe oligospermia patients. And that can help us in prognosticating the couple to go for invasive surgical procedure or go for repeated ejaculations, etc. So it is very important to do both these investigations simultaneously, both karyotyping as well as Y-chromosome microdeletion.
Microdeletion, yes. And suppose a person with azoospermia comes and you're gone for micro TC, which you said is useful with those with a C factor, which is having a deletion. How much is your success rate?
In C factor deletion, we can quote 50% to 80% of 50 to 80% of such successful sperm harvest in C factor deletion, and that's what the medical literature says. So, quote a
your voice is breaking. Can you repeat again, because we couldn't hear?
We should always quote a range and not a particular number.
Okay.
Because that's what various different papers have been published in medical literature, and they quote different success rates. So we can quote them a range of 50 to 70% about in azoospermia factor C factor deletion.
Is there a particular method of doing the TC? Because you see the volume of the testes and then go for that particular testes, or you take a sample, you take from every whichever you think is right side, left side. Is there any particular method of choosing the testes for taking a sample in Azu?
Ideally, micro TC is the procedure of choice, but not it requires infrastructural investments. So if one has to go for a regular TC, then we can take the larger size testes, which is more denser in consistency, and choose that instead of the other one, and we can go for a regular TC in that case.
Okay. And any relation to RPL when you have severe OATs or azoospermia, recurrent pregnancy losses?
Actually, RPL is more connected with DNA fragmentation index. So, along with semen analysis, if a patient has a higher DFI, particularly more than 30%, then such patients are known to have either recurrent implantation failures or recurrent pregnancy losses.
Okay.
So,
how do you counsel them?
With higher DFI, we can either aspiration of sperm, which is usually good as far as DFI is concerned, because it is not exposed to seminal plasma.
Okay.
Or we can give them 3 months course of good combination antioxidants containing lycopene and L-carnitine and all that.
What is the choice of your antioxidant?
Any good combination antibiotic is antioxidant is good. Even simple non-costly antioxidants like vitamin C, vitamin E, and zinc are sufficient. So we don't need to go for the fancy, really expensive antioxidants like astaxanthin and lycopene. Even non-expensive, simple antioxidants and multivitamins are sufficient. They have the same clinical outcomes as the really expensive ones.
How long will you give antioxidants before you take them off?
At least for 2 months. At least, ideally for 3 months, but at least for 2 months.
Any use of probiotics?
Not that I'm aware of. I have not really read papers that probiotics can increase the chances of successful sperm harvest. One thing I would like to add on is, though one can go for varicocele surgery, particularly if there are clinically significant varicoceles, then before going for surgical sperm harvesting, one can go for a varicocelectomy and wait for 2-3 months. And that is shown to be in some published papers increase the chances of successful sperm harvest in such patients.
Any indication for clomiphene injection, HMG and all that in these cases?
If there is a ratio abnormality, if the E2 by T4 ratio is more than 50, if it is abnormal, then one can go for estrogen to testosterone reversal by giving an aromatase inhibitor 2.5 milligrams of letrozole a day, or even clomiphene citrate 25 milligrams a day and 5-day break, that kind of a thing, if there is a E2 by T4 ratio abnormality. But in case of the estrogen is normal, it is not elevated, and if the testosterone is also normal, then there is no role of clomiphene citrate or HMG or FSH injections. It is empirically, and there is no evidence behind it.
So would you test for estrogen levels before you start treatment for azoospermia?
If there is a clinical suspicion, if the patient gives a history of this sexual dysfunction, if there is no loss of libido, if there is a gynecomastia, if there is abdominal central adiposity, those patients are typically those which have a higher estrogen ratio.
What is the normal level in a male, Dr. Rutuj? Estradiol?
Estrogen should be less than 20 picograms per ml, and
Okay.
testosterone should be about 250 nanograms per ml. So
Okay.
if there is a reversal, then one can go for clomiphene or aromatase inhibitors. There is
So-
coming emerging for support of letrozole
Okay.
rather than clomiphene citrate. So one can even give aromatase inhibitors to reduce the estrogen levels in such patients.
Because many start empirically clomiphene or letrozole without a logic. That's why I
No,
wanted to ask.
not recommended. Not
Okay.
recommended.
And they think that it will help because that just prolongs the agony for the patient, because the results do not happen when they just give
Exactly.
haphazardly.
And
And
again, there is no evidence supporting
Yeah.
use. So
And any indication for HMG?
HMG can be given if there is a hypogonadotropic hypogonadism classically, in which case we can give 150 units thrice a week or every alternate days. And I've seen very good results with hypogonadism because it has components of both FSH and LH. So it first leads to elevation of testosterone, and slowly after 2-3 months we can start seeing sperms in the sample. And there are instances wherein patients have conceived with HMG injection, particularly hypogonadism patients.
So you have to prove hypo before you start them on HMG. Just empirical HMG will not help every azoospermic patient.
In idiopathic azoospermia, no.
It doesn't matter at all. And this is actually not regarding azoospermia, but what is the test for DNA fragmentation you prefer?
Sperm chromatin dispersion assay, madam.
Dispersion.
SCC. Yeah, it's the most simply done as well as inexpensive.
Thank you so much. I know I've troubled you, but excellent lecture, and you give such great inputs. Thank you so much. Before I ask our treasurer, Dr. Manjula Appadurai, to give the vote of thanks, I'd like to thank you personally for all the I know we have troubled you, but you have done such a great job for us. Very, very clear presentation. Thank you.
Thank you,
so much for that. I'd like to thank all the delegates who have joined in. This is our usual numbers because they come for a very intensive discussion. When there are no questions, they are just appreciation for you. But the talk is excellent. So any other doubts, we'll call you for another meeting so that you can clarify for us. Thank you so much.
Thank you so much.
I'd like to thank Shield Pharma for all the help, and may I request the treasurer, Dr. Manjula, to give the vote of thanks. Thank you so much. You have to unmute yourself, Manjula. Manjula, you have to unmute yourself.
Good evening, sir, and good evening all the delegates who have joined in the AART webinar conducted today. Thank you so much for such a wonderful presentation and lecture. We all have gathered so much knowledge from this, and I hope our approach towards azoospermia male patients will be in a different manner from today onwards. Hope so. And the way you answered all the questions from our Dr. Chamla madam was really amazing. And we benefited a lot from those answers from you, sir.
Thank you, ma'am.
Thank you so much. Thank you, sir. Thank you so much. And I thank Gynaecologist madam, Dr. Shanti madam, our president, and all the Dr. Chamla madam, and all the delegates for joined the webinar for this evening today.
Thank you, Manju. Thank you, Shanti.
Thank you.
Bye. Thank you, Shanti Priya.